Good morning, ladies and gentlemen. I would like to thank Professor Benazzo for his indication to address this conference. I wish I was in Italy, but I'm afraid on this occasion I'm unable to get there. Professor Benazzo has asked me to talk about the indication and limits in robotic hip surgery. In my practice, I am a complete enthusiast, and I use it in all routine primary hip replacements in patients under the age of 85 and in complex primary hip replacements for all of the indications listed here. It is extremely useful. We will learn much more about the relationship of the spine and the pelvis, and you can change the position of the components to address problems with spinopelvic instability. This is a work in progress. The only cases I don't use it for are patients in whom I would prefer to use a cemented cup, such as patients over the age of 85 with poor quality bone. I do use it in revision hip surgery, although the software is not yet validated for this indication. The advantages really are that as the patient has a CT scan, you can do patient-specific planning in 3 dimensions, allowing a huge accuracy and precision of socket placement, of getting the leg length right, and of getting the correct version that suits the anatomy of that patient. Because especially if you use a cemented femoral component, you can change the anti-version of that implant. And in my practice, the other thing that's really revolutionized it is that the robot has allowed me to preserve more tendons. And I routinely use a technique known as spare, where the only tendon that is divided is obturator externus, which is repaired later. Really, to get the very best results for any indication, you need a stepwise method for planning that case. Clearly, the history and examination, including that of the spine, is very important. And you need to take into account the anatomical changes on the side you're going to operate on, but also on the opposite side, because you may wish to balance the hip in a different way in terms of the leg length and the offset. So you need to know if there's any developmental abnormality on either side or any pathological bone deficiency and excess. And then in terms of socket planning, you'd plan the size of the implant. You can change the center of rotation in any plane, and you can change the inclination and antiversion of the implant. On the femoral side, you can choose a stem of the correct offset, dial in as much or as little antiversion as you wish, put the stem to the correct position to get leg length. And obviously you will choose a stem of the correct size. And it's much easier. And in my cases, I only use cemented femoral components because all of these things in femoral planning are then independently variable. So what are the steps on the socket side? Really, these are the parameters to be optimized. The depth of the walls, medial, anterior, and posterior, the surface area of bone removed in order that you get good grip of the cup and a good interface. And then you want to know where the face is in relation to the bony anatomy. So these individual things are the things you want to optimize. And then, so therefore you choose the socket size, move the center of rotation, and decide the orientation to get these parameters optimized. And you go through an iterative process, choosing these things until you've optimized the walls, the area, and the face of the cup. So as an example, you can see this left hip replacement is 2 millimeters shorter compared with the contralateral side. For the walls, first of all, we will change the center of rotation in all planes to get the walls correct. So that you can see on this particular case, I've moved the center of rotation 2 millimeters from where it was starting, 5 millimeters medially, and you can then look in the sagittal plane at how much bone is being taken, and in the transverse plane at how much bone is being taken. And you can scroll up and down with this window to see how much bone has been removed. You then want to know the area of bone that is going to be removed. And the green is where you will ream bone away. So that you can see here, you've got really quite nice amount of bone being taken out for grip of the cup. And you can rotate the image to make sure that underneath the lip at the top here, that you're taking enough bone out. by changing the inclination and the version, you can change the amount of bone you ream. And of course, it will affect the face of the cup. So with the cup in 40 degrees of inclination and 20 degrees of version, you can see the front wall is quite nicely hidden. There is a bit of an overhang at the back, which is normal with an uncemented implant. And then you can also see where there might be osteophyte to remove. On the femoral side, these are the parameters to be optimized. You want to get the offset correct so that the soft tissues are balanced. You want to get the version correct. You need to get the leg length appropriate to that you've planned for the other side. And you need to get the stem size correct for the patient. So those are the parameters, again, that you want to optimize. And so you choose the offset of stem that you want. You decide the amount of antiversion you want in order to get the correct combined version of socket and stem. You can plan how far down into the femur to put your implant. And of course, you get the correct stem size and position doing this. And then you revisit all of these until you have optimized the parameters, the offset, the version, the leg length, and the stem size. And the great thing about a cemented taper slip stem is that offset, version, leg length, and stem size are all independently variable, which is not true of uncemented devices. You will know the work of Professor Catani in Bologna, who has done a lot of work looking at femoral version and found a huge range of native version. He described the antiversion of the femur as being pathological in up to 55% of cases, and retroversion was the most significant deformity. Now, the beauty, of course, of using a cemented implant is that you can decide to dial in as much or as little version as you wish, and you're not compromised in any way. So in this particular case, I've chosen a 37.5 millimeter offset stem. And you can see that although I've got the leg length correct compared with the opposite hip by how far down I've put it, the offset is decreased. So I want to use a stem that has a bigger offset. So I've changed now and chosen a 40 millimeter offset stem. It's been inserted to the correct depth to get the leg length right, but you can see the combined offset is now much more realistic. The 3 dots here are the center of rotation of the stem, the center of rotation of where you plan the socket to be, and the native center of rotation. And so here you can see the final position with the cup 45 degrees and 20 degrees with the 44 millimeter offset stem, and it predicts what the post-operative film will look like. And in most cases, that is exactly what it does look like. What about more complex cases? Well, it's very useful in dysplasia. So you can see in this left hip is 15 millimeters shorter than the opposite side and has an 11 millimeter increased offset. The beauty of this is that going through this iterative process, you can work out where to put the center of rotation to optimize the depth of the walls, to get it to the correct position in relation to the medial side, and the orientation. So here I've chosen 45 degrees of inclination, 18 degrees of antiversion, and I've moved the center of rotation using these buttons 3 millimeters inferior and 10 millimeters medial and 5 millimeters posterior in order to get the center of rotation optimally placed in the bone. And you can predict whether you are going to need a wedge or some autograft bone in these cases. If you look on the sagittal plane again, you can see how much bone is being taken. Again, look at the 2 dots. The green is the center of rotation of your planned cup. The magenta is the host anatomy. And then the area, you will see the amount of green that is being reamed away. And again, you can rotate the pelvis to look underneath the edges to see what is being taken. Obviously, you're going to take some inferior bone away. And then looking at the face of the cup, you get an idea of any osteophyte you will need to remove or any excess bone. And you get an idea of whether you will need a wedge supralaterally. In this case, it was not necessary. You can predict what the X-ray will look like. And then on the femoral side, you can see the native version was 42 degrees. Well, we're going to correct that and with a cemented implant, reduce that. But you can plan not to fully lengthen it. We're going to plan to put it 13 millimeters longer but still leave it a little short compared with the contralateral side. Since the patient has been walking around like this all their life, you probably don't want to absolutely fully correct it. And then you can see what the post-operative film will look like. What about an ankylosed hip? Again, very, very useful here in complex cases. You need to adapt the method, but in terms of getting the parameters correct, it's the same iterative process. So you can see this patient is 16 millimeters short, has a 3 millimeter increased offset. You can plan where to put the cup in the same sort of way, get an idea of where you need to remove bone. You can plan the offset of the stem, again, the 3 dots of the center of rotations. So we're planning to put this so that it's going to be 2 millimeters shorter than the opposite side, but 14 millimeters longer than it was. And then during the operation, you will teach the robot where the host bone is by touching the cortex, and it will tell you, define where to make your initial cuts and where to remove bone. So here we are intraoperatively with the wand, touching the bone and working out where to make the initial cut. And then you can use the robot to help you remove bone, and then of course orientate the socket in the correct place. So that's the final plan, and you can see what the predicted post-op X-ray will look like. In fact, in this case, because the open trabecular bone was so good, I used a cemented cup, but it helped me get all of the other parameters correct. And when you analyze the X-rays, I've now done several hundred of these, you can see that it puts the cup where you want it in every case. And then the final thing that I mentioned that really has changed my practice is using the robot in conjunction with changing the technique to approach the hip. So I use this, what's called the SPARE technique. SPARE stands for saving piriformis and obturator internus with repair of externus. And I believe it consistently preserves more tendons than any other approach to the hip. So with a normal posterior approach, you would cut everything on the right-hand side of this line. With the SPARE technique, you preserve obturator internus, the 2 gemelli, and the only tendon you cut is obturator externus. And because the access to the acetabulum is a little compromised, the robot really helps get the socket in the correct place every time. So now the standard of care in my practice, my absolute routine, is to use a cemented femoral component, a uncemented acetabular component put in by the robot using the SPARE technique. And if this technique does interest you, there are tips and tricks, and it is demonstrated on ViewMedi. Thank you very much indeed for your attention.